Oh, right. Thank you, Susanna, for that introduction. So as she said, I'm going to be talking today during this webinar about how we can use extracorporeal shockwave for lumbosacral disease in dogs. This is definitely a big passion for me because I do like geriatric and palliative care. And I think a lot of times when we think about lumbosacral diseases in dogs, we're a little limited in how we can help these dogs. So I just want to add another tool to our tool belt in terms of how we can manage and improve dogs' comforts and mobility. Um, so Suzanne did a great introduction for me already. She talked about kind of my bio. So I do really integrate lots of different things when I'm treating my patients. I integrate acupuncture, rehab, and then I'm newly certified in veterinary spinal manipulative therapies as well. So I kind of try to implement everything together to try and get the best results. And I definitely love having Shockwave as one of my tools for helping patients move better. So just a brief outline about what we're going to be talking about today. I'm going to do a very short case introduction that we'll circle back to. We'll give a basic review of shockwave history and how it works. We'll also talk about the most common indications and review of current evidence, as well as a review of just what lumbosacral disease is, the components of DLSS, and the anatomy of it so we have a better understanding, and then treatment approaches and protocols for these myelopathies. So for my brief case introduction, this is Bentley. He's a 10-year-old lab. He presented to us for decreased mobility. And he, as you can see in this video, he's pretty hind limb paraparetic, ataxic. He also has a bit of a hip hike. And he's just not really wagging his tail. So a lot of owners, will correlate a tail wag with their dog just like being very sad, very depressed, and they just felt like he wasn't living out the best of his senior years. So we're going to talk about how Shockwave is going to help Bentley have a better quality of life, and the change for him is quite robust. So in terms of Shockwave history, it was derived from lithotripsy. So this was a procedure used to fragment urinary stones. This was done in the 1970s in people. And what they noticed in people was that people who also had hip disease and were getting this lithotripsy behavior were having an improved pain response on their hips when they were getting this urinary procedure. So this led to a lot of different experiments in the 90s, looking at animals and the response of shockwave and bone, and they found that there was a significant osteogenic response and higher bone healing when they were using shockwave therapy. And then in the 2000s, they've used that evidence to try and extrapolate it to using things for arthritis, soft tissue, and bone healing. So Zomedica and PulseVet, have been together since about 2020. They introduced their shallow trode in 2022. I've been really lucky. I started my residency in 2020, so I've had the PulseVet Shockwave for my entire training. And I definitely saw the difference when they introduced the shallow trode. It feels different. It's really nice to not have to sedate our patients when we're using it. And it's made a world of difference in terms of which client selection and patient selection we can use Shockwave for. So what exactly is shockwave? So this is going to be a high energy sound wave. Basically, that's going to occur anytime there's a big electrical impulse passing through the atmosphere. So the most common analogy is going to be a lightning storm, right? So you have this huge electrical impulse. As it changes the pressure in the atmosphere, it creates a thunder that we hear. And then we also not only hear that thunder, but we feel that thunder because basically that energy is being transmitted through the environment. And there's different types of environment, right? So there's air and there's water. And when we're talking about sound, there's different attenuations with air and water. So if you're in a big empty room and you're screaming, the further away you are, you're going to lose a lot of that sound energy. But if you've ever heard sounds in water, it's actually really amplified. So there's actually less attenuation in water, which makes it more profound and higher energy. So with shockwave, you have these low frequency, high pressure, high velocity sound waves, which are kind of the opposite of ultrasound, which is another type of sound wave therapy that we think of, which is more commonly higher frequency, low pressure, and a bit thermal emitting. And it's going to convert these sound waves into pressure mechanical waves. And as they encounter environments of different acoustic impedance or kind of density properties, they're going to have different energy releases as they encounter these different changes in densities. So not only does it have just a release of energy, but what it does is they generate these cavitation bubbles that basically can absorb the pressure, and then with this gas or air that's created, it's going to eventually collapse and create a microjet, which creates a second pressure wave. So we get a really profound energy effect. And this is what happens in the body. So, tissue is basically 70% water. So it's going to really have a low attenuation. So you're not going to lose a lot of that energy. And then as it's encountering different surfaces, so skin, fat, tissue, bone, you're going to have changes in energy release. So this is my favorite Zomedica video that they made that really amplifies kind of what that soft cavitation effect that you have in tissues are like. Let's make sure. So with this figure, basically they shot a gun in water and they have these little bubbles. So as you can see, they're going to initially absorb that energy. They're going to hit a point where they can't absorb any more energy, and then they're going to collapse and then create a microjet for more pressure. So with shockwave, commonly we talk about either focused or non-focused shockwave. Non-focused shockwave is more of your radial pressure wave. I think of it more almost like a Theragun. It's pretty broad. It's not very deep. You're not going to feel it a lot. Versus focused shockwaves, they basically produce pressure waves from electrical energy that's converted to mechanical energy. You're going to have greater tissue depth penetration with a rapid decline of energy in the periphery. So you're having this really focused area of this energy deliverance without damaging the surrounding areas. So with focused shockwave, there's 3 types. The one we're going to be talking about is electrohydraulic, which is what the PulseVet is. So they have this spark gap. They have this electrical impulse. It's going to create this ellipsoid shockwave. And because it's ellipsoid, it's going to reflect back and create a secondary shockwave. So it creates this really big focal zone. Compared to piezoelectric or electromagnetic, where piezo, you have collapsing piezo crystals, and then electromagnetic is kind of similar to a loudspeaker, where you have a very, very tiny focal zone and you don't get as much pressure release. So in the body, what do we do with this shockwave? Like, how is it therapeutic? So basically, when you have this physical shockwave, you're going to have an immediate biologic response. You're going to have a reduction in substance P, so really good pain response. You're going to have a release of cytokines. So when you're dealing with chronic soft tissue injuries, it's basically going to reactivate that acute phase and recruit all your anti-inflammatory mediators. It's going to release a bunch of angiogenic growth factors, so things like VEGF and PCNA and von Willebrand's factor. So you're going to have a lot of neovascularization. You're also going to have a release of bone morphogenic protein. So you're going to have bone regeneration, healing. You're going to activate your tenocytes, so your tendon cells. And it's just doing all these great things to the body. So you're going to have osteogenesis, tissue healing, endothelial cell proliferation, and neovascularization. So with these effects, you do have some side effects. They're very mild though. So sometimes you can see petechiations, bruising. Very rarely you'll see interstitial damage of the arterial walls or temporary aggravation of the symptoms. So I'm never using it like directly over a vessel if I can help it. Usually if I'm using it over a big vessel, I'll actually like use my hand and hold it away. So if I do the neck, I'm kind of holding that jugular away and protecting it with my fingers, just because I'm a bit more cautious. But overall, it's very minimal side effects. So because of all the things that it does for the body, the common indications for shockwave are going to be analgesia, so great pain relief. It's great for osteoarthritis and OCD lesions. Because of that increase in bone morphogenic protein, we use it for a lot of your non-union or your delayed union fractures. Again, activation of tenocytes, so tendinopathies and ligament injuries, wound healing for that neovascularization. And then a little less talked about is things like chronic IVDD, facet arthritis, and lumbosacral stenosis. So, the title of this lecture is lumbosacral diseases. So we're going to be talking about those chronic IVDDs, facet OAs, and lumbosacral stenosis. So I'm very evidence-based. I want to recommend a product that I know is effective. We're really lucky with PulseVet. They are pretty robust in their research. So in the animal side, there are several papers specifically looking at back pain and lumbosacral disease. So there is an Allen et al. Paper from 2010, and they found a significant effect on horses for back pain. So they had a higher threshold for nociception. And then there is the Kim paper that looked for cauda equina syndrome treatment with shockwave in cats and dogs, and they found a significant reduction in pain. And then most recently in 2025, there was a podium abstract looking at the effect of extracorporeal shockwave for lumbosacral pain, specifically in dogs, and they used the canine brief pain inventory as their measurement, and they found a significant improvement in CBPIs for these dogs treated with lumbosacral disease. On the human side, the studies are actually more robust, so they're doing systematic reviews on lower back pain and shockwave. There's 2 systematic reviews. One came out in 2023, and they found for chronic lower back pain that there was a significant pain reduction. And then in 2021, they also had one just for treating chronic lower back pain, and they found it was an effective mechanism of treatment. So talking about the other portion, the other focus of tonight's webinar is lumbosacral diseases in dogs. So the most common lumbosacral diseases, there's obviously degenerative lumbosacral stenosis, or DLSS, which is a multifactorial disease. There's intervertebral disc disease, trauma, infectious diseases like your discal spondylitis. You can also have facet degenerative joint disease or septic arthritis, sciatic neuritis, and also acute caudal myopathy, or also known as limber tail. So those are the common diseases, but just backtracking a little bit, it's really important to understand your lumbosacral anatomy in dogs to really understand how these disease processes work and how we can effectively improve upon them. So with dogs, they have 7 lumbar vertebrae, they have spinous processes, and then they kind of have these really big transverse processes coming out of them. But not only do they have just their vertebrae, but they have a ton of connective tissue in between them. So you have your supraspinous ligament over your spinous processes, you have your interspinous ligaments, you also have your dorsal longitudinal ligament and your ventral longitudinal ligament, as well as your interarcuate ligaments. So all of these ligaments, when there's abnormal motion, can get inflamed and have or scar down and fibrose and basically change the posture of the dog and also the mobility and cause pain. So with your lumbosacral spinal cord, it's important to remember that they don't correlate directly, like the spinal cord number doesn't correlate to the vertebral number. So with lumbosacral disease, it's important to know that your spinal nerve roots for L4, 5, 6, 7 are actually coming out of your L3, 4 vertebrae. And when we talk about cauda equina syndrome, really the cauda equina is closer to L5, 6 vertebrae segments, not all the way down in that LS region. So clinical signs of patients who have lumbosacral disease, commonly you're going to see a change in posture. So with our case, Bentley, he has pretty bad kyphosis of his lumbar spine. He also has dorsal tilting of his cranial pelvis. In that initial video, he has hind limb weakness. He's pretty short-strided and he has a stiff hind limb gait. He also was painful in his caudal lumbar spine. He was very resistant to tail jack. And then even with him in the still picture, you can kind of see that he's been barbering around his lower hip area or his lower back. So he's trying to figure out what's uncomfortable for him. And usually you'll see those kind of barbering signs. I think a lot of times owners think they're like pressure sores because they've kind of lost muscle and gotten older, but also the dogs are kind of self-mutilating as well. So the biggest disease process is going to be degenerative lumbosacral stenosis, or DLSS. And like I said earlier, it's multifactorial. So the multiple factors include hypertrophy of those ligaments that I talked about. You're also going to have degeneration of your lumbosacral disc. You can have degenerative joint disease of the articular processes. And you can also have lateral spondylosis at the level of the LS junction or your SI joint. You can also have dynamic compression of the cauda equina. So like I showed you in that picture, the cauda equina is fairly high up in your lumbar vertebrae around L5, L6. And sometimes these cases, they'll have an MRI and it'll look normal and you're not understanding why this dog is weak or in pain. And it's really important for dynamic compression that you do 2 views. So not just the standard MRI of the lumbosacral, but also extending out those hips and changing the angle that the lumbosacral junction is sitting in, and you might see different types of compression. Same thing with the narrowing of the LS intervertebral foramen, that can all be positional. There are also dogs who are just born with congenital stenosis of the vertebral canal and also born with transitional vertebral anomalies. So who is getting DLSS? these are commonly going to be your older, medium to large breed dogs. They're going to be working or sporting German Shepherds. Your males are more predisposed than your females. And then where it's going to occur is most commonly in the L7-S1 region. So I always like to relook at anatomy to really understand the disease process, right? So with your normal disc anatomy, you have your nucleus pulposus and your annulus fibrosus, and they're going to push up under these dorsal longitudinal ligaments. The ventral longitudinal ligament is underneath of it. But also in that intervertebral foramen, you have your spinal nerve roots. You have your dura mater and your arachnoid, all trying to protect your spinal cord, but also just surrounded by bone. So all those changes we talked about are going to change how the canal looks and how the spinal cord is feeling. So when you have interarcuate ligament hypertrophy, you're going to have dorsal compression. When you have a disc herniation, you're going to have ventral compression. And then those osteophytes are actually going to try and narrow the area where the canal is for the cauda equina and your lumbosacral spinal cord. Not only that, but osteophytes are going to limit motion. So I think a lot of times people don't think of vertebral joints similar to how you think of like an elbow or a stifle joint. And we know with arthritis for distal limb joints that, stagnation or not moving is going to lead to decreased lubrication of those joints. The same thing happens in the vertebrae. If you're not moving normally, you're going to have less lubrication. The synoviocytes are not going to be creating synovial fluid. You're going to have more and more degenerative disease processes. So those congenital transitional vertebral anomalies, in case people are a little confused of what that is basically, I talked about the normal anatomy of your lumbar vertebrae. So they're normally going to have these long transverse processes, and they don't actually join your ilium because that's your SI joint, right? Your sacroiliac joint. When they're transitional, basically they take on characteristics of your sacral vertebrae. So you can see on the right side that this lumbar vertebrae is actually part of your SI joint, but on the other side, it still has its transverse process. So this abnormal motion is going to change how your pelvis moves. And again, every time you have aberrant motion of your joints, you're going to have degenerative processes occur. With spondylosis deformans, it's definitely a pet peeve of mine that radiologists are always like, oh, just incidental spondylosis deformans whenever they see x-rays, because as someone who specializes in mobility, spondylosis deformans does change an animal's mobility. It limits that flexion and extension of the vertebral bodies. It limits that axial rotation. That's how we get twisting and bending motion. And all of that has changes to how the animal moves. It can cause that dynamic compression that we talked about earlier. So I really feel very passionately that it's not just incidental. Another component of DLSS is discospondylitis. So this is going to happen in your Labrador retrievers and your German Shepherd dogs. Again, males more predisposed than females. And what it is basically an infection. It's going to be either bacterial or fungal of your intervertebral discs and your vertebral bodies. So it's most commonly going to occur in the L7-S1 IVD space. And why it occurs is for a multitude of reasons. Most commonly, it's going to be a urinary tract infection. You can have bacteremias from prostatitis, but you can also have nosocomial affections, so from spinal surgery or penetrating wounds or foreign material. So what it looks like is that you're going to have this whole collapse of the vertebral end plate. So instead of that nice smooth outline at the end of your vertebral bodies, it's going to be hazy and irregular. It's going to be hyper intense as well. And then usually the body is trying to recover. So it forms that bridging spondylosis when you have pretty severe discospondylitis. Another process that we can see is sciatic neuritis. So this is going to happen in your medium to large breed dogs, generally with active lifestyle or sport trained dogs. And basically what it is irritation or inflammation of your sciatic nerve. So the sciatic nerve is one of, the biggest nerves of the hind limb, but it also has its spinal nerve roots from L6, 7, and S1. So the compression can occur at the nerve roots or can occur more distally. And this can happen from stenosis or IVD or just inflammation of the soft tissue surrounding it. So just kind of getting a better picture of the anatomy. These are your sciatic nerve roots, and this is kind of how the sciatic nerve travels through the pelvis, and then it also gives off to your common peroneal and your tibial nerves as well. The last one I want to talk about is acute caudal myopathies or limber tail. This is going to happen to your working or your hunting dogs. These are going to be English pointers and Labrador retrievers. They are basically going to have a strain or a sprain of their muscle groups for tail movement, and it's also going to affect the soft tissue surrounding your caudal and sacral vertebrae. So most commonly, it's going to happen from direct trauma, so like a happy tail situation. But in the working dogs, we see it a lot with climate changes or overexertion from vigorous play. But you can also see it with, chronic anal gland diseases or anal gland impaction infections, prostatitis, or descending cauda equina. I'm not sure what's going on. My slides aren't moving. Oh, there we go. Sorry about that. So what are kind of treatment options when we're talking about lumbosacral diseases? So our go-tos are going to be, oral analgesia. So NSAIDs, things like gabapentin, pregabalin, amantadine, or steroids, so trying to calm down that inflammation. From a rehab standpoint, we can use things like epidural, so doing a steroid, opioid, or local anesthetic epidural. And then for exercises, we can do strengthening exercises, trying to help that paraparesis, strengthening that core so that you have less aberrant motion to the vertebrae. But also we do things like nerve glide exercises. So especially for things like sciatic neuritis, you're trying to make sure that there's no distal compression of the nerve. And then we have our modalities. So, things like laser, electrical modalities, acupuncture, heat, CC loops, and then shockwave, which is what we're going to talk about today. So just to kind of refresh you guys about Bentley, we're going to be using shockwave on him, and I just want to go back a little bit to like the settings for the machine. So if you are kind of research based or you like to research and read about shockwave, they talk a lot about energy flux density, which is basically how much energy is transferred per pulse per millimeter squared. So bigger is not always better, right? So you want to use it actually on the lower energy side to get that cellular regeneration, pain therapy, and that pseudarthrosis. You don't want to exceed it and get lithotripsy. We're not trying to break down these bones when we're trying to treat things with shockwave. We're trying to get that pain relief and those immune-mediated responses and those anti-inflammatory mediators. So for your pulse vet, this is provided with your machine, but generally if you have one in your facility, you see settings such as E1, 2, 3, 4, 5, and 6. So this is the correlation of what E6 looks like, is about 0.33 millijoules per millimeter squared, which is going to get that cellular regeneration, that pain relief, and a bit of that pseudarthrosis, but not enter into that lithotripsy portion. So what I really like about PulseVet is it's super user-friendly, and they have really common protocols. So for lumbosacral diseases, they're recommending that E6 energy level, so 0.33 millimeters per joule squared, and about 750 to 1,000 pulses. There are some contraindications you should know for shockwave. So generally not using it for immune-mediated joint disease, exposed CNS, infectious areas such as septic arthritis and discospondylitis, near gas-filled organs or cavities, unstable fractures, directly on metal implants, pregnancies, fetuses, eyes, and then neoplasia. So, I talked about things like discospondylitis and exposed CNS. When you have these cases of lumbosacral disease, sometimes they have dorsal laminectomies, sometimes they have discospondylitis, and how do we kind of navigate around that? So generally for me, I will still treat patients who have had dorsal laminectomies. I'm usually waiting about 4 to 6 months. I just want to make sure that there's a good fibrous capsule where that laminectomy site is. And then for infectious areas, as long as they're already on antibiotics, then I'm comfortable starting the treatment area so they're not seeding that infection. So just to circle back to Bentley, I like to talk about kind of static images and dynamic images. So with him, again, he has that lumbar kyphosis, he has that dorsal tilting of his caudal spine. He just seems overall uncomfortable. And then on his initial presentation, again, he's pretty weak. You know, he has that hip hike, he's crossing over a little bit and no tail wag. So with Bentley, just to give you a bit more background on him, he does have DLSS. So on his MRI, he has multiple areas of chronic IVDD. So you can see that his intervertebral discs are desiccated, they're dry. He has multiple areas of mild herniation. He also has significant spondylosis around T12, 13, and 13L1. And then in his lumbosacral space, there is distal spondylitis, spondylosis deformans, severe narrowing of his lumbosacral cord. And then on the axial image, he has bilateral neuritis of those spinal nerve roots. He has pretty bad end plate damage. And then you can also see that he has some heterogeneous material just adding to that compression of the spinal cord. So this is Bentley after his second shockwave. So happier dog, obviously. And now you can see he has a bit of a tail wag. He's not really hip hiking and he's not crossing over as much. So just another view of him. So again, more robust tail wag, very, very limited crossing over. It's still a little narrow strided, but overall he's just moving a lot better. So in terms of positioning, you know, I'm not aiming to try and get the spinal cord by any means. What I'm trying to do is address possibly the spondylosis deformans, the facet arthritis, so that osteophyte formation that he's having, all of that soft tissue ligament hypertrophy. So his supraspinous ligament, his interarcuate ligaments, all of those things, and also all the surrounding musculature that's been acclimating to kind of his changes in posture. All those are contributing to his discomfort. So with the trode, I'm going to aim it usually directly dorsal, but then I also aim it from the caudal aspect, trying to get all of those ligaments. And then for him, hopefully you guys can all hear this. So again, we talked about the PulseVet has a shallow trode. So he has not had any sedation on board. It is quite loud, so I use ear protection for the dogs because I find that they're actually just more sensitive to the sound more than anything. Sorry, I just didn't want to talk over the shockwave. So basically, he's just very gently being restrained. He's laying down. Most of the dogs I have when I'm treating them for lower back pain, they do just lie down and they kind of ease into it. I have had even one dog fall asleep when I'm doing it, even though it's so loud. I'm obviously shaving the affected area, so I have direct contact. I'm using a water medium, so I'm not losing that energy. And then I'm kind of going through that entire region of where those nerve roots are coming out. So all the way up from L3, L4, all the way down to the LS region of the vertebrae. For him, because he has kind of that limber tail, I'm also giving him some gentle tail traction, really trying to get into all those soft tissue areas surrounding the tail. And as you can see, it's just very, very well tolerated. So this is Bentley today. You can see just from the static picture, he has a lot of improvement in his kyphosis. He doesn't have as aggressive of that dorsal tilting of his pelvis, and he's not really barbering around his hip region. And then he's also just really strong. So he's really, really happy. He has a really, really robust tail wag. He's doing cavaletti, so his coordination's great. He's able to do three-legged stands and kind of, you know, whack us with his hands. And he's just overall very, very comfortable. And I think, as you can tell from the first video to this video, he's just so much happier dog. And that's really kind of the magic of Shockwave, is you get these really robust responses almost immediately. And owners really see these changes. And, you know, I think with neurological diseases, I'm always stressing patience with my clients. But with Shockwave, we kind of get these almost immediate responses, which are just really lovely. So that was my presentation, kind of short and sweet. This is my email if anyone has additional questions that we don't get to today, as well as our rehab department's Instagram page if you want to see really cute dogs getting Shockwave and doing underwater treadmill therapy. And I would love to field any questions you guys have.